I'll be discussing the oxygen therapy and use of non-invasive ventilation strategies in COVID-19. First, I will discuss the basics of physiology, and second, I will discuss about the oxygen delivery devices. Third, I will discuss what you should clinically do in the bedside to a COVID patient. So, as you all know, oxygen is essential to sustain cellular metabolism in all aerobic organisms. But when it comes to oxygen therapy, oxygen is a drug with a prescribed dose. Okay, you should never exceed the dose, or you should not compromise the amount of oxygen that is required for the patient. It is always a double-edged sword. Always remember about the reactive oxygen species and the problems associated. This diagram shows the oxygen cascade. Okay, it's nothing but the flow of oxygen from the atmosphere through the airway to the alveolar gas, arterial blood, ultimately to the tissue, and to the ultimately reaches the mitochondria, where the metabolism takes place. The major metabolism takes place. Atmosphere, it is around PaO2. The partial pressure of oxygen is 152. When it in the airway gas, it is around 149. In alveolar gas, it further comes down. The arterial blood is something around 90. And in the tissue, it further the amount of PaO2 further lowers, and the mitochondria level, the PaO2 is around 5 millimeters of mercury. So 150 is 9 to 5. This flow to the various steps is called the oxygen cascade, and the various formulas are there at each level. And one important equation is the alveolar gas equation, where the PaO2, the alveolar oxygen partial pressure, is is determined by FiO2, and the atmospheric pressure, the vapor pressure of the water vapor, and PaCO2, and respiratory quotient. And the respiratory quotient again depends upon the substrate which is used for the metabolism, the fat, protein, and carbohydrate. AA gradient, it is basically the difference in the oxygen tension between the alveolar and arterial blood. And the gradient, as a gradient, it is just the efficiency of the gas exchange between the alveoli and the capillaries. Basically it gives you idea about how effective the oxygen exchange takes place between the alveoli and capillaries. Oxygen dissociation curve is this is oxyhemoglobin dissociation curve. It is sigmoid in shape, as you all know, and PaO2 is a major determinant of saturation. And important thing in this graph is, if you see the topmost portion, to whatever level increase the oxygen saturation beyond a higher value, the PaO2 remains stable. Okay, in a COVID-19 patient, usually there is no point in increasing the oxygen level, oxygen saturation beyond 94, or there is no much difference in the PaO2 when you keep the oxygen saturation in the 94 or 95 or even 100. So usually we our target should be kept around 94 to 95% of the oxygen. Okay. And oxygen delivery, oxygen is transported in the blood, both in bound to hemoglobin and dissolved in the plasma. And there are 4 types of hypoxia basically, and what we are dealing with is primarily hypoxia in COVID-19 patients. Hypoxia is basically inadequate oxygen at tissue caused by lower arterial oxygen tension due to multiple factors. Okay. In COVID-19, it is primarily the lung which is which is affected, and other causes of hypoxia is maybe high altitude, hypoxic gas mixture, decreased alveolar ventilation, weak UV match, right to left shunt, and diffusion impairment. The important point about the hypoxia is it is a hypoxia which has maximum benefit with the oxygen therapy. Okay. Anemic hypoxia, where oxygen carrying capacity of blood is decreased and oxygen tension is normal. it happens in anemia, carboxyhemoglobinemia, and methemoglobinemia, and the oxygen therapy do benefit in anemic hypoxemia. And stagnant is or ischemic hypoxia is where the arterial oxygen tension and SV are normal, but blood flow is compromised. Okay, like in low cardiac output state, hypovolemia, arterial obstruction, or thrombus. This hypoxia also respond to oxygen therapy. And the last major hypoxia in classification is a histotoxic hypoxia or cytopathic hypoxia, where the failure of organ for utilization in presence of, despite of the presence of adequate tissue PaO2. That means the blood is supplying adequate oxygen, but it's not able to utilize. It is mainly due to the dysfunction of the electron transport chain. Typical example are cyanide poisoning and in sepsis. Okay, the problem with this hypoxia is it does not respond to oxygen therapy. Basically, oxygen therapy is administration of oxygen at concentration greater than that in room air to treat or prevent hypoxemia. Either it may be orthobaric, where it is given at ambient atmospheric pressure, or it is hyperbaric, where it is given at a high but a higher than atmospheric pressure. Okay. Oxygen delivery devices are basically grossly divided as a variable performance device and fixed performance devices. In the variable performance devices, it is the FiO2 which is achieved depends upon the patient's peak inspiratory flow rate or the patient's respiratory drive and effort. Okay, the low oxygen, it is basically a low flow oxygen delivery system where our nasal cannula, face mask, and the non-rebreather face mask are the typical examples. Fixed performance devices where the FiO2 delivered is constant despite of the change in inspiratory flow rate, and usually it is a high flow oxygen delivery system. Typical example is the HFNC, the Venturi mask, oxy mask. In a way, anesthetic breathing circuits are also a fixed comes under fixed performance devices. The important thing to remember in this is a normal patient, when he is normally breathing, his tidal volume is within the physiological limits. But when the lung is damaged, like in COVID-19 patient, the lung is pathological, then the patient's oxygen demand goes up, patient's respiratory drive goes up, patient is dyspneic, tachypneic, patient's tidal volume increases, patient's respiratory rate increases, and it ultimately results in higher peak inspiratory flow rate and higher minute ventilation. Okay, so a low flow oxygen delivery device is designed to meet the a normal respiratory pattern or just higher respiratory drive. Okay, but when patient is grossly tachypneic, when patient require a lot of oxygen, a lot of minute ventilation, it starts endraining air from the outside. And this causes the oxygen concentration to dilute the oxygen, and ultimately FiO2 will not be achieved. Okay, but the high flow oxygen device system or fixed performance device make sure high flow oxygen is delivered and the FiO2 requirement is met, because the high flow demand of the patient is met by the high flow delivered by the system. Okay. Nasal cannula, as you all know, it is typically operate in the flow rate of 1 to 6 liter, and at 6 liter it delivers approximately or about 0.44 FiO2, but it again depends upon the respiratory drive and the minute ventilation of the patient. It is easy to use and basically a low flow oxygen administration system, and it is less restrictive, and it does not increase the dead space, and most importantly it allows the speech, and it allows the patient to eat and drink during oxygen therapy. Simple face mask increase the size of the oxygen reservoir beyond the limits of anatomical reservoir. One point to remember is oxygen flow of at least 4 liter per minute should be given, should be delivered through simple face mask, because it will prevent the rebreathing. If you keep it below 4 liter per minute, patient will be rebreathing the carbon dioxide, and it will be more dangerous in a patient who is dyspneic. Okay. So it delivers when the oxygen, when nasal prongs are insufficient. It is simple. It is simple to use, lightweight, and it gives a FiO2 around 0.6, depending upon the flow rate and the patient's respiratory drive. And COVID-19 ward, you will be familiar with this device. This is nothing but an RBM. This is non-breather face mask. It has a reservoir bag attached to the fresh gas flow. So this fresh oxygen flow, and there is a one-way valve between the reservoir bag and the patient. And the most important point is there should be sufficient flow so that the reservoir bag is at least partially or fully full during the inspiration. Okay, so typically what the recommendation is, at least 10 liter or minimum 8 liter of flow is mandatory to keep the reservoir bag partially expanded. Okay, then only patient will be able to inhale the oxygen with a high respiratory drive. The delivery, it delivers high FiO2. Typically, it operates in 8 to 15 liter or 10 to 15 liter, and FiO2 delivered is higher. It is around 0.6 to 0.95. Now the Venturi mask, it's also a fixed performance device where 100% oxygen is delivered through a constriction. Due to Bernoulli's effect, there is a pressure drop around the constriction, and there is entrainment of the second gas, and there is jet mixing, and oxygen inflow is connected to a specific color-coded entrainment devices as shown in this figure, which is fixed for each FiO2. And there is also adjustable Venturi valve, and it provides a set FiO2 at a set oxygen inflow rate. Okay. It's typically operate at the FiO2 of 0.24 to 0.5 with the oxygen flow of 4 to 15 liter. Okay, and with the gas entraining, the flow delivered to the patient will be around 35 to 45 liter per minute. Okay, this is a new system which has an innovative pin. This is Oxy mask. It has an innovative fin and a diffuser system, and it typically concentrates and redirects the oxygen flow. Okay, there is a mushroom shaped pin you can see in the figure, which redirects the oxygen flow. It forming an organized pattern of vertices and a cloud of concentrated oxygen. And FiO2 will be the function of oxygen flow rate compared to the inspiratory flow and tidal volume. Okay, so the Oxy mask functions over a large. It's capable of delivering in the entire oxygen therapy range. That is 20.24 to almost up to 0.95 is the oxygen concentration delivered, depending on the flow. Okay, and all other devices has a narrow range of operation as far as the FiO2 is concerned. And it Oxy mask allow you to use a straw and drink with a straw. This is important because while feeding, the hypoxemic patient rapidly desaturates. Okay, so Oxy mask may help in that aspect. HFNC, the most important oxygen therapy device as far as COVID-19 is concerned. Yeah, HFNC basically supplies heated, humidified, high flow and high FiO2 oxygen, and it has a hair oxygen blender. It gives up to 1, or let us say it is around 0.95 FiO2, and flow rate depending upon the manufacturer, it is up to 60, some provide up to 50, and high oxygen flow is delivered, as I said earlier. Constant oxygen is delivered with a fixed FiO2, though the patient has high inspiratory flows, where patient has high respiratory drive. Okay, and the heated humidifier is important. With high flows, it prevents drying and preserves the mucociliary clearance. Okay, so basics of the physiology, how the HFNC works. It flushes the nasopharynx during exhalation. Okay, so the inspired air is oxygenated with the HFNC gas, and during next inspiration, it improves the oxygenation. Okay, and high flow rate of the HFNC is closer to the inspiratory flow rate in a dyspneic patient, in a COVID-19 patient. Okay, it washes out the anatomical dead space, improving the ventilatory efficiency, and it ultimately reduces the respiratory rate by slowing of the exhalation by the inflow of the gas. Okay, and it do reduce some amount of the work of breathing, and due to all this cumulative effect, it reduces up to some extent the work of breathing is reduced. Okay, and one another important aspect of HFNC is the PEEP. uh, Always there is during expiration there is a flow provided by the HFNC which increases the expiratory impedance. Okay, and especially it peaks during the early exhalation. The PEEP in a typical HFNC at a flow of around 70 liter per minute, PEEP is around 7.4 centimeter of water, and roughly you can say it around 1 centimeter of water of PEEP per 10 liter of high flow. Okay, so it comes around 6 or 7 PEEP when you give uh, 60 liter per minute flow. Okay, but the important pre-sequence is maximum PP is delivered to the patient if the HFNC is properly fitted and the mouth is closed. Okay, and ultimately PEEP increases the end expiratory lung volume. It keeps the alveoli expanded. Okay. Let us see the indications of HFNC in COVID. Any impending respiratory failure, if the patient does not respond to your standard oxygen therapy with the other oxygen equipments like NRBM, you can go for HFNC. But one important thing to remember is whenever if the patient has a very high work of breathing, NIV is not your good choice. Okay, either you should go for HFNC, either you should go for NIV, or if the work of breathing and desaturation is like very high, like there is work of breathing is very high, even consider intubation. Okay. So it helps in post extubation in COVID patients. You can alternate with NIV and HFNC. So always remember the most important thing is when the work of breathing is very high, don't go for HFNC. Always take precautions while using HFNC. It's generate lot of aerosols. Preferably, it should be operated in a negative pressure room if available, or at least 6 to 12 air exchange per hour should be there. And HEPA filter, if available, it should be used. And make sure the nasal prongs are fit or the HFNC is properly fit. And many smaller studies have demonstrated putting a surgical mask over the HFNC will reduce the aerosolization. And the most important thing is your proper PPE and proper N95, proper fit of the N95 of the healthcare workers uh, to avoid getting infected. So how to operate a HFNC? See, always remember when the patient is moderately severe or severe, always start with the highest HFNC settings and titrate down. Okay. So if the patient is severe or moderately severe, initiate the maximum flow, 50 or 60 liter per minute. FiO2, always start with FiO2 of 1 or 100%. Okay, or say the whatever maximum with the your machine. Okay, and start with highest temperature, that is 37, and titrate down. Okay, so initiate with the full settings and titrate down. That is the best practice. But when it comes to a mild to moderate, you can start even with a 50% FiO2 and or a 40 liter of flow. But Once you put the patient on HFNC, patient should be properly assessed. The clinical parameters, how the patient respond to the HFNC, how the oxygenation parameters are going on. This is most important. Somebody should be there monitoring the patient and always monitor the respiratory rate, the breathing pattern, and preferably ABG should be checked after half an hour of HFNC. After half an hour of starting HFNC, and you can even alternate the HFNC with NIV if the work of breathing is high, and always consider awake proning with HFNC. So HFNC failure should be picked up earlier, and you should proceed for either NIV or intubation. Okay. The ROX index is described in the pre-COVID era to see the HFNC failure, but the crux of the treatment of the HFNC or how to predict the HFNC failure depends upon the clinical skills. Okay, always see the patient, clinically see whether patient's the work of breathing is increasing, patient is more tachypnic, patient's accessory muscles are like working, whether it is respiratory distress is worsening, what is the oxygenation, what is the saturation, and you should have a continuous pulse oximetry going on, how the ABG values are, like whether the PaO2 is worsening or whether there is carbon dioxide retention. These are the important factors should be monitored, and you should closely monitor for HFNC failure. Okay, so ROX index, it is simple one. You can the formula is SpO2 by FiO2 by respiratory rate. Okay, so ROX score of 4.88 at 12 hour predicts the success of HFNC. Okay, ROX score of less than 3.8 at 12 hours suggest a HFNC failure. In this table, you can see more than 4.8, your patient is stable and safe on HFNC. 3.8 to 4.8, patient need close monitoring. 2.8 to 3.2, better to shift the patient to ICU, and always below 2.8, consider intubation. But don't always rely on the ROX score. Your clinical judgment, that is more important, whether your patient is going for patient's work of breathing is increasing, whether patient is more tachypnic, whether oxygenation parameters are worsening. This should be the this should guide the your continue your decision to continue whether on HFNC or NIV. So grossly, COVID-19 is divided according to respiratory status to the mild, moderate, and severe disease. And in the moderate disease, respiratory rate will be more than 24, or the saturation will be around 90 to 93. Severe disease, saturation will be less than 90, and respiratory rate will be more than 30. And if you look for an algorithmic approach for respiratory failure, always if the patient is saturation is less tachypnic, patient comes in the moderate category, and patient saturation is around 92 to 94 or 90 to 94, first you can try simple oxygen supplementation via nasal cannula, that is around 6 liter or 4 to 6 liter. If worsens, you can go directly to NRBM, or first try oxygen mask and then go to NRBM. But a worsening hypoxemia on NRBM or simple oxygen mask, you should proceed to the next step, that is moderate respiratory failure, where the non-invasive strategies plays a role. These are basically HFNC and NIV. Whenever there is a increased work of breathing, opt for NIV. Whenever patient has a COPD or a cardiogenic pulmonary edema with COVID, because these COPD and cardiogenic pulmonary are the classic respiratory failures which respond very nicely to the non-invasive ventilation strategy. So go for NIV. Okay. and always try awake proning with whatever oxygen, whether it is standard oxygen therapy or HFNC or NIV. Whenever possible, do awake proning. And most importantly, you should identify the patient when the patient is failing on your non-invasive strategies. That is, when the patient is failing on HFNC, when the patient is failing on NIV, it is your duty. It is most important to pick up the patient, pick up that the patient is failing on NIV, and you should not delay the invasive mechanical ventilation. Okay, in the initial part of the COVID, people used to delay unnecessarily the invasive mechanical ventilation, which ultimately resulted in increasing mortality. Okay, so whenever the patient is more worsening on the NIV or HFNC with a PF ratio less than 150, patient is hemodynamically unstable, and there is a if there is a impending respiratory arrest, never hesitate to go for invasive mechanical ventilation. Just few words about the awake proning. Always use awake proning with whatever modality, whether it is standard oxygen, whether it is HFNC, whether it is NIV, or even after mechanical, after initiation of invasive ventilation, proning should be done. Patient, it helps a lot. Patient, most of the patients respond to proning, and let us see how it reduces the alveolar over distension in non-dependent area. It reduces the collapse of alveoli in the dependent areas. It improves the VQ mismatch, and it improves the shunt, and there is drainage, a better drainage of respiratory secretion, and the ventilation becomes more homogeneous. It can be done, the awake proning can be done alone or with HFNC or NIV. Okay. The last part, NIV, the interfaces of NIV may be either nasal mask, oro-nasal mask, nasal pillows, oral mask, total face mask, and helmet. NIV basically augments the tidal volume and it improves the alveolar ventilation. It lowers the PCO2 and improves the PaO2. It counters the PEEP provided by the during NIV ventilation, counters the intrinsic PEEP. It increases the end expiratory volume. It opens the atelectatic lung units, and it reduces the work of breathing. It generates high mean airway pressure. This is and it also has some effect on the cardiac output, cardiac function. It decreases the preload and the afterload, and it also helps in some way. It helps in improving the cardiac output also. In the pre-COVID era, this used to be the classic indication for an IV. In this, most important are acute exacerbation of COPD, the cardiogenic pulmonary edema, and in the post-extubation patients, NIV was used with a good outcomes. Okay, so if a patient with the acute exacerbation of COPD comes with the COVID, you can always opt for NIV if the patient failed for standard oxygen therapy. Okay, if a patient comes with cardiogenic pulmonary edema, fails on oxygen standard oxygen therapy, rather than going for HFNC, go straight away to the NIV. The indication of NIV in COVID-19 is again the impending respiratory failure, COPD exacerbation, cardiogenic pulmonary edema, and HFNC failure. In HFNC failure, you can try a short trial of NIV. It gives a better inspiratory pressure, okay, and inspiratory support and better PEEP. Okay, and in the post-extubation, extubation patient, you can combine with NIV, HFNC with NIV. Okay, always remember the absolute and relative contraindication to NIV use. Okay, impending cardiac arrest, impending respiratory arrest, severe upper GI bleed, patient high risk of aspiration who are not able to protect the airway, and uncooperative patients are contraindications to NIV. And always take COVID precaution. Preferably NIV should be used in a negative pressure room. But if it is not there, always use your PPE and properly fit a 95 mask. And helmets are preferred, especially in Western countries. They prefer helmets or oronasal mask than the other interfaces because it reduces the aerosolization. ICU ventilators should be used if available, and better to put a viral filter on the expiratory limb to avoid aerosolization or to reduce aerosolization. How to initiate an IV? You start with a PEEP of around 8 to 10, PSV of around 12 to 15, and high. You first start with a higher FiO2. In NIV also, always start with a moderate or high settings, then titrate down. Okay, so titrate down, targeting a respiratory rate less than 20, and your SpO2 target should be around to keep it around 92, and your target should be around 88 to 90 in a patient with COPD. Once you put the NIV, the important thing is always monitor for NIV failure, and never hesitate to intubate if the patient is failing on NIV. Don't stretch out the patient of on NIV. It ultimately result in crash intubations. There is higher chance a patient may during the intubation patient may become hypoxic, more hypoxic. Patient may go for a bradycardia and cardiac arrest. Okay, so if there is early signs of NIV failure, always go for invasive ventilation. The watch for clinical improvement. Basically, just see the patient whether the tachypnea is worsening or settling, whether patient is oxygenation is improving, the saturation is improving or not, and preferably check a ABG after half an hour. And you should always watchful about the delivered tidal volume. Okay, because NIV, the patient has its own effort. A tachypnic patient always sometimes tends to take the tidal volume in thousands. Okay, sometimes 1.5 liter per tidal volume, 1.2 liter. This will add to the ventilator-induced lung injury, self-induced lung injury, and you can titrated dose of sedatives can be used in the patient, but never over sedate the patient. If the patient is stable on NIV, NG tube can be used for feeding. NIV is difficult to use in a claustrophobic patient. Whenever there is aspiration risk, avoid NIV or look for aspiration. And as I said earlier, self-induced lung injury due to excessive tidal volume should be always be monitored. And PF ratio less than 150 is always go for invasive ventilation. And if you continue a patient with COVID ARDS with a PF ratio less than 150 on NIV, high chance that you will lose that patient. Okay. So the NIV failure, the predictors, the important is again clinical only. There are many scores. One is HACOR score, which takes into account heart rate, acidosis, conscious level, oxygenation, respiratory rate. It predicts the NIV failure, and maximum score is 25. And any score more than 5 at 1 hour of NIV has more than 80% of 80% risk of NIV failure. But always remember that don't go behind these scores. Okay, the most important thing as a respiratory physician or a intensivist is you should always patient should be on NIV, should be in front of you, or there be a trained person to see for NIV failure, and you should pick up the patients who is failing on NIV and proceed for invasive ventilation. Okay, and roughly saying a patient who is becoming more tachypnic, patient is desaturating on IV, and patient is requiring a FiO2 requirement of more than 60 or 70. These patients are not going to hold too long on the NIV. Proceed with invasive mechanical ventilation that will improve the chance of survival. Okay. So with this, let me conclude. Thank you all.